So now we'll talk a little bit of light, contrast and glare, because management of this is very important for low vision patients. Now what happens is, if you see the table down below, this is what the illumination that is required for normal viewing by a normal person. You require about 400 lux of illumination for reading and sewing, and for watchmaking you really require very high illumination like 2000 lux. So normally it is about 300 to 600 lux. That is the normal illumination you require for normal everyday activities by a normal person. But a low vision person will require very high levels of illumination, which is about 1000 lux, because that helps to increase the contrast to the patient, and it also helps them to break through the mistiness of his vision and see clearly. So how can you get this high level of illumination? Very important and very easy. Make the patient sit in natural light, and if he's sitting near the window, then the patient will receive about 10,000 lux of illumination on a bright day and 2,000 lux on a cloudy day, which is more than sufficient for him to do his reading, writing and near tasks. The next is to consider how to provide 1000 or more lux with artificial lighting. So the first thing to remember is to use a lamp like that shown in the picture, which is a goose neck lamp, and you can mold it, and you can twist it, and you can turn it so that the light falls exactly where you want it to fall, which is on the object of regard, which may be a book or writing or sewing material. And you can use this formula, very simple formula to remember. Illumination is equal to luminous intensity of source divided by the distance of illuminated area from the light source. So very simple formula to use. And if you're using a 100-watt bulb in the lamp and you're using it 2 feet away from the book which is being read, then this formula gives you a calculation of 250 lux of illumination. If you want to increase it, you bring the lamp closer to the book, and with the same wattage of bulb, 100 watts at 1 foot, you get 1000 lux of illumination. So when you play with the distance and the wattage of the bulb, you can produce as much as 8000 lux of illumination on the object of regard. So this is how you manage the artificial light sources. Then there are certain important considerations. First is the consistency of the source, which is very important, because if a single tube light, it produces a lot of flickering because there's a ballast in the tube, and that produces flickering, and especially if the tube light ages. So to counter the flickering, you can have 2 tube lights together, and that one flickering of one tube light will counteract the flickering of the other and cancel it out. So you'll have a consistent light source with 2 tubes or multiple tubes. The second is source deterioration, because with age, the tungsten filament in an incandescent bulb will go down and will require to be changed, because the illumination produced will decrease with time. So to keep changing the tubes and the bulbs at regular intervals. Type of source is very important, whether you should use incandescent bulbs or fluorescent bulbs. So this is very important, because for low vision patients you have to choose an incandescent regular yellow bulb. Why? Because fluorescent sources, whether they are CFLs or regular tube lights, they've got a lot of UV and blue light scattering, and that is very detrimental for low vision patients because it reduces the contrast, and as you all know, it also impinges upon the functioning of the retina and produces macular degeneration. So a lot of blue light in the surrounds of a low vision patient is very detrimental. Yellow light is very important. It has got virtually no UV and blue, so that is very important for low vision patients. And the fourth thing to remember is that the background illumination must be only 20 to 50% darker, otherwise there will be a lot of accommodative efforts and fatigue to the patient. So now what is the best bulb to use? There you see the emission spectrum of a regular incandescent yellow bulb. So you can see there is very little blue emission, but a lot of red and infrared emission. So this mimics the daylight sunlight pattern too. If you look at CFL lights, you can see the blue peak over there. Very bad for low vision patients. Very bad for us too, also normal people. And here is LED. Everybody is replacing their bulbs with LED lights, and LEDs have got very sharp blue peaks, as you can see in this slide. So CFL and LED bulbs are not recommended for low vision patients. only a regular incandescent bulb is the best and ideal for low vision clients. So now we have to talk about glare also, because glare is very disabilitating to a low vision patient. For us also it is very disabling, and for them it is more disabling. So glare can be produced either indoors or outdoors. So if there is a lot of glare to the patient outdoors, you can advise him a hat with a brim, or ask him to wear sunglasses or visors. And if glare is very disabling indoors, then the patient should be advised to put blinds and curtains on the windows, or use tinted glass on the windows, or work with back pointing towards the window. Now for outdoor use, there are a lot of absorptive filters that you can use, and these decrease glare and enhance contrast. So they are available in 5 tints. As you can see from top to bottom, they are gray, amber, orange, yellow, and plum. So they are available as standalone glasses or as over prescription eyewear, and the transmission range for different wavelengths is 80% to 2%. So let's discuss them in a little bit more detail. So all these absorptive filters, sunglasses, so the gray ones are basically Polaroids, and the amber, orange, yellow, and plum are made of polycarbonate. All of them block UVA and B 100%. Now the Polaroids, the gray ones and the amber ones also decrease the transmission of light equally for all the wavelengths, and therefore they are very good protectors from glare. Best used outdoors. Alright? And the orange, yellow, and plum ones, they predominantly cut off the UV and blue light. So they are very important for increasing the contrast for low vision patients. But the only disadvantage of all these colored absorptive filters is that blue color appears black when you wear these glasses, and the color green is not seen. Now let us talk a little bit in the next section about pediatric low vision. So a child who has got low vision has got a lot of problems with motor development, orientation, and it impinges upon his scholastic performance also in school. So it is mandatory that soon as you identify a child with low vision, you treat him as soon as possible. But sometimes when the child is small and pre-verbal, it becomes very difficult to even assess the vision of a child and what potential it holds for him. So for that, it is important to remember the visual developmental milestones, as you can see in this chart over here. That at birth to 4 weeks, a child develops fixation and follows horizontally, objects horizontally. And at 5 months, he develops the blink response, so on and so forth. So if a child does not follow the VDMs, then you must immediately suspect that he has got profound vision loss. So following this or knowing this will immediately make you suspect if a patient or a child has got vision problems or not. So up to the age of 4 months, these are the various ways in which you can also assess vision, like measuring pupillary reaction to bright light, head turn towards light source, or blink response to bright light. In pre-verbal and infants, you can use the Catford drum, VEP, and preferential looking. On the right hand side, on top, you can see the grating acuity LIA paddles. And these are very popular for measuring visual acuity in pre-verbal children by preferential looking. Then for verbal children who are older than 3 years old, you can use tumbling E, HOTV test, Sheridan Gardner, Cambridge crowding set, but these are very expensive, ranging from 20,000 to 50,000 rupees. And at the bottom, you can see a very popular chart, which is the LIA symbol chart. For those who have got profound visual loss, you have to perform functional vision assessment, and that is the only way in which you can know what the vision is, whether he can perceive light or not, what is using the light for, is vision for, how much vision he has got, and all this. But this is a very specialist thing which normally we don't perform in our clinics. And once the vision loss is identified, or residual vision in the form of perception of light, direction or source of light is identified, you put the child on 3 levels of instruction programs to appreciate light, the direction of the light, where it is coming from. Put him on level 2, which is improving his visual efficiency, And then level 3, which is making him learn how to navigate on the streets and in well-defined pathways. So that is how you help a child with profound visual visual loss to cope up with the vicissitudes of life. And these are few pictures to show you how this is done, how a light is projected and a child taught how to appreciate light and the direction of light and shape of light. And this is a light kit which you can obtain from US, very expensive. I don't have it in my clinic. We don't do it. What we do is the most simple thing. If we have identified a child with profound visual loss, we refer them to specialists. And for me, that is the National Institute of Visually Handicapped in Dehradun or the Blind People's Association in Ahmedabad.